Prostatic adenocarcinoma is the last topic that we're going to discuss. Again, adeno means gland, and carcinoma means malignant. So this is a malignant proliferation of glands, of course, involving the prostate. Prostatic adenocarcinoma is the most common cancer in men, and it's the second most common cause of cancer death. Risk factors include age. As a person ages, there's an increased risk for prostatic adenocarcinoma. Race. Prostatic adenocarcinoma has a higher incidence in African Americans. Slightly beneath that is the incidence in Caucasians, and then slightly less than that is the incidence in Asians. So it's relatively more common in African Americans and less common in Asians. And another risk factor is diets that are high in saturated fats. Here's a cross-section of the prostate. Notice that the urethra runs through the center of the prostate. Now it's important to note that prostatic adenocarcinoma, which is the lesion that I'm circling here, occurs in the posterior periphery of the prostate. So the most common location for prostatic adenocarcinoma, again, is in the posterior periphery of the prostate. Now that's important because notice that it's very far away from the periurethral zone. And so therefore prostatic adenocarcinoma usually does not produce urinary symptoms until very late. Only if the cancer were to grow extensively and actually compress the periurethral zone would you get urinary symptoms. So generally speaking, prostatic adenocarcinoma is actually clinically silent and no urinary symptoms are usually present. Therefore, in order to detect prostate cancer, we need to screen. And so screening begins at the age of 50 with both digital rectal exam and PSA. Now recall that if this is the prostate here and it sits anterior to the rectum, then the digital rectal exam is actually analyzing the exact location in which prostate cancer usually occurs. Because remember that prostate cancer usually arises in the posterior periphery of the prostate. An additional method of screening is the PSA. The normal PSA ranges from anywhere from 0 to 4 nanograms per deciliter. Now as patients age, that normal PSA can increase such that the range from 4 to 10 is sort of a borderline number in which, depending on the age, it may or may not be elevated for a particular patient. However, once the PSA gets to be above 10, that's highly worrisome at any age. And so that would then prompt us to become particularly worried about prostate cancer. Another way by which we can screen is to look at the free PSA in the serum. Now generally speaking, cancer makes bound PSA, so that a decrease in the percentage of free PSA would be suggestive of cancer. Now when the clinical suspicion is sufficient, then a prostatic biopsy will be performed. And it's important to note that in order to make a diagnosis of cancer, this is required. You cannot assume that the patient has cancer based on a high PSA or an abnormal digital rectal exam. So a prostatic biopsy must be performed before the prostate would ever be removed. On biopsy, we would classically see small glands that infiltrate the normal prostatic tissue, and one of the high-yield characteristics of prostate cancer is that the nuclei, which I'm outlining here, contain these dark nucleoli. Again, the nuclei contain these dark nucleoli, and that's particularly characteristic for prostatic carcinoma. The grading of prostate cancer occurs via the Gleason grading system. Very high yield to note that the Gleason grading system is based on architecture alone and that nuclear atypia is not considered in the Gleason grading system. In order to perform the grading, multiple regions of the tumor are assessed. Now the reason for this is that there is high variability in the architecture of prostate cancer across the tumor. So we actually have to look at multiple regions and then score different regions in order to come up with a final score. Now this is classically done by looking at the two most common patterns that exist within the cancer. Those patterns are scored anywhere from 1 to 5, and then the two scores are added to produce a final score, which would range from 2 to 10. The higher the score, the worse the prognosis. But again, the highest yield here is that the Gleason grading is based on architecture and not nuclear atypia. One of the important things about prostate cancer is that it often likes to spread to the lumbar spine. When it spreads to the lumbar spine, it produces osteoblastic metastases, such that rather than getting lytic punched-out lesions, you get these sclerotic lesions of the bone. Now this would present with low back pain, and the alkaline phosphatase would be increased. Again, alkaline phosphatase is a sign of osteoblastic activity, indicating that bone is being laid down, and we're well aware of the fact that we get osteoblastic metastases with prostate cancer. In addition, we might see an elevation of PSA or the prostatic acid phosphatase, both of which are serum tumor markers for prostate cancer. Here's a picture of the osteoblastic metastases involving the lumbar spine, and so you can see this area of sclerosis within the spine. With local disease, prostate cancer is treated with prostatectomy, so that is removal of the prostate. If there is advanced disease, continuous GnRH analogs, such as leuprolide, can be used. Now the idea here is that the GnRH analogs, when continuous, they shut down the hypothalamus, which then reduces luteinizing hormone and FSH, which would then in turn decrease the ability of the prostate cancer to thrive because, of course, prostate cancer is androgen dependent. In addition, we can use androgen receptor inhibitors such as flutamide, and again the notion here is that prostate cancer is dependent on androgens in order to grow and thrive. And that concludes both the section and this chapter.